Everybody hear me? Great. All right. Thank you everyone for being here for this afternoon session, and welcome to our panel this afternoon titled Expanding the Basket of Contraceptive Options. I'm Liz Millar, and I'm a research associate with the University of North Carolina, where I focus on monitoring, evaluation, and learning around reproductive health and other areas. And I'll be your moderator for this session today. So we have 4 very exciting presentations during which our speakers will share with you their experiences with expanding the basket of contraceptive methods available in different contexts, with a focus not only on the methods themselves, but making those methods accessible to clients. In these presentations, we will hear about introducing or expanding access to various contraceptive methods, the local systems in which they are operating, and the different actors, including policymakers, advocates, providers, and community health workers, as well as the clients and considerations for the context of each of these local systems. When it comes to contraceptive options, we know that the preferred method varies for each client, and the access to each method varies within the context of that local health system. So today we're going to hear from each of these speakers about reaching potential users, understanding the audience for various methods, and eliciting user feedback on their experiences with each of these methods. So we'll have about 15 minutes for each presentation, and I will ask you that you all hold your questions until the end, and then we'll have time for questions and hopefully have an engaging discussion. Okay, so our first speaker today is Dr. Lopamudra from Pathfinder. Dr. Lopamudra has a doctoral degree and about 20 years of work experience in program monitoring and evaluation with a focus on health, population, and development. She brings synergy between research, IT, and MEL through her technical skills on qualitative and quantitative analytics and organizational ability in planning, monitoring, and evaluation of programs and leading research studies. I will also add that she is a wonderful artist. I can ask her about that later. Dr. Lopamudra will speak on Pathfinder's recently ended project on the introduction of injectable contraceptives to the basket of choice in India's family planning program, and speak about how this has empowered women in their reproductive choice through a holistic implementation approach. So I'm going to hand it over. Please come down.
So, good afternoon. I know the post-lunch sessions are the most difficult sessions when people have to stay awake and to listen to us. But I also would like to say that I think the all presentation will be very interesting and it will keep you awake. So I start with our India experience. The first one is for in today's session is the India experience when we're talking about injectable contraceptives. So how that has been added in India's basket of choice for contraceptions and how that has been given the women's reproductive rights. So if we look at this, this is a DHS data in India, and it shows that the beginning in 2005 and 6, there is minuscule or almost nil use of injectable contraceptive in India. But when you see that NFHS 4, which is called National Family Health Survey, which is in 4th round and 5th round, you can see there is an improvement for injectables because it has been introduced to the system in 2016, and slowly it has been taken up, and you can see in 19 and 21 is a recently ended our DHS survey has shown there is an improvement. But this is actually not enough. Here I'm going to talk about how this has been become a holistic approach to put it in within the baskets. So how it has happened that I talk about our initiative called Salamati program, which has been done in government of Haryana, which is talking about improving the reproductive health of women, in the young women, and also especially for the 15 to 24, but we have reached to everyone, and to show that how it has been increased the access of modern contraceptives, special reference to injectables. So if you can see here, and there is in one state of in India where there are a lot of districts. So Haryana is one of the state in India. It's in a northern part of in India, and here you can see that there are 7 districts where Pathfinder International has implemented in a program, a holistic approach program with Government of India, where they introduce injectable contraceptive in all the districts. But here we have an other component which has given more importance to injectable contraceptives. So now we can see that what were the other component we have added up and what are the things we have actually done for make the difference. There are 3 components. You can see here very categorically it is doing for the 7 districts where increased access of this, but it is not only the access, because government is given access to everyone, right? Everybody has access when something is introduced in the government program. So what you do, basically you have to engaging the community and also generating the evidence which you can take the learning, which you can take it forward for the other place, which are all talking about the scaling up approach. So that we are going to, or I am going to talk about how it has been happened. You can see that we started with the capacity building of the staffs, because injectable is a contraceptive which has been added in the government system. Definitely the government staffs need to be have some kind of exposure to it, need a capacity building. And also you can say that we call a stress check, right? If a lot of people are coming to your health center to asking for a services, you have to have that capacity to deliver those services. So we have done those, almost you can say 8,000 staffs has been, their capacity has been built during this program period. And here also I would like to say the majority of them are the ground level workers, which called ASHA workers, who are community health worker in India. So further that, I know the capacity building, but look, people do that for the lot of trainings, round up trainings, but you know that more important nowadays, people have found it out, the supportive supervision and mentorship program, because it is not only one-time training. Training can give you a lot of knowledge, but actually the hand holding is improvement, giving the skills to the people. So that is more important, and this project has actually done the mentorship program, and as well as giving the hand holding and supportive supervision support to those people whose capacity has been built. So that was very important on this program, and those 7 districts we have done that. We have also for the healthcare provider, there is an application, an app has been developed, which is called Impari, which is available in Google Play Store. Everybody can download. It is for the healthcare provider, which is given all contraceptive methods there, everything about, and also the MEC wheel is also there, so people can choose that what is the right contraceptive for the right age group of people and who's needed. So you can see that help that is developed during this project period. Later on, we have used that also for another project, a BMJ funded project called YUVA, for the same purpose. So that point of time, there was more than 1,200 provided during that project period who have downloaded this app and used it. However, right now we have more than 4,000 downloads for this app. And a lot of people and a lot of testimonials also is given that the people found it is very useful. It is not only the capacity building. Now you have to give it a proper infrastructure also. The people need privacy to talk about contraceptive. We talk about the full access, full choice, but it is also necessary to know to give them the counseling where the people have retained their privacy. So there are a counseling corner in the health facility has been actually designed and built up, so which has given people to the access and they can talk freely during this period. Now, finally, I would come to that how the community has been engaged. As I said, that it is in a 360-degree approach completely from the supply, demand, and enabling environment. So if the community has been came up with creating an enabling environment also with the 52 female counselors who are trained and they address the people need in the community. You can see that almost more than 57,000 one-to-one counseling has been done. There are a lot of follow-up visits. You know, the contraceptive, this injectable contraceptive needs a lot of follow-up. Otherwise, there are a lot of dropouts. The adherence is one of the things. So that is more important. So there are a lot of follow-up visits has been, group meeting has been done in the community to make it in a peer group, making the people to talk about that what is the good thing they have learned about it and how they can share to their peers. So that is the way it has been done. And then you can see here that the counseling, then the screening, and then you have given the service provision. So this has been happen, and it was given like till the subcenter level. Now, here coming the results. So what? We have done something for a quite a bit long time, right? So we are all expecting to get some great results. So here, when I look at these great results, you can see that all the districts where the Pathfinder has been worked with this holistic approach is actually total acceptors of them, the 70% belong to those districts. So that's matter. So that means the giving only the thing in the basket of choice to people is not enough. You have to have a community awareness generation. You have to make the service sector providers to build their capacity, and as well as you have to make an enabling environment also. It's very much important for the women to access what is offered to them, because there are a lot of things are there, but they may not have either the awareness or the knowledge or the accessibility for that. So after the counseling, you can see that this particular injectable, which is DMPA, it has been actually become the second most after the condom, which is very, very important thing, because otherwise in India, it means condom and OCP is taking the thing in all the reversible contraceptive. I'm not talking about sterilizations. So he's only talking of the reversible contraceptive method. And then you can see also there, you found it out that the people who are basically in the lower parity, they have opted for this particular method, as well as people who are in a younger age group. So these data also show that the DMPA has been used probably mostly for the spacing of between the children. I have talked about right now all good things, right? I think everybody was thinking, oh, that's a really great project, we have done it, and everything is good. But here, I want to tell you that everything is not good. Something is also challenge. I would say that all the project, that is very much important to know what is called the learning. We say that we saw here that people have been dropped out after the second dose or the third dose. That was the continuity, the adherence of this particular injectable contraceptives was what a challenge for us to keep people. So that's why I said the follow-up is very much important. Follow-up is not for the counseling. The people who have adapted it, the continuation is more important. So you can see the top 3 reasons why people have said that they dropped out. Among them, people have talked about the side effects. So they have dropped out. They opt for a different method, for that the method switch has been happened. They wanted also for the social pressure, or you can say that there is some commitment towards the other engagement, so miss the date. The day they're supposed to go, or the time they're supposed to go for the next dose, they have missed that time. So that was the thing, and that is the place where you need your community health worker to be intervened to those people to monitor and to target and to either bring them to that mainstream or also give them another contraceptive choice methods to be used to avoid the unwanted pregnancies. So if I'm looking for those, particularly this data, NFHS, which we call DHS in India, has given us a very good, thing in those 7 districts where you can see the changes has been happened. It's a large scale survey, right? It's in a big amount of data which has been shown that how the differences has been made during this period for DMPA. Finally, I would like to say, which I have started with a note, that actually adding the method of the basket is not everything. You need to do something more. So government program is definitely adding the thing, but we at the development sector partner or with the researchers here who has come up with a lot of research and findings and talk to the government about that it need a completely holistic approach where you can start with the supply side with the capacity building of your staffs. You have to do a community awareness, community motivation to the people to adapt the new methods, and also very much important to also do some kind of side effect management, because you can see that one of the major cause for dropout was a side effect. So people have to do that. And also I would say this counseling corner, giving the privacy and regular follow-up, those are very, very important things. So women, we are talking about that we are giving people, are giving women and wings to using a new contraceptive in their basket of choice. That's not enough. We also have to provide them something more to actually to fly with that wings. Thank you, everyone.
Thank you very much. And our next speaker will be Dr. Queen Amina Bayobaku, who is the Associate Director and Head of Clinical Services and Training at DKT International, Nigeria. Dr. Bayobaku is a medical doctor, a reproductive health specialist, as well as a certified sales, leadership, and management consultant with over 12 years of experience in this field and more than 10 years of experience in leadership and management capacity. Her client portfolio includes a significant number of hospitals and healthcare providers from the public and private sector who testify to her passion and her unique ability to teach and simplify practical strategies for personal and organizational success. So today we'll get to hear Dr. Biobaku discuss the introduction of Kaya in Nigeria, a non-hormonal user-initiated method to expand contraceptive choice and access.
Hello, everyone. So I'll be talking about expanding the basket of contraceptives methods in Nigeria. Thank you. So Kaya diaphragm is a non-hormonal, discrete barrier method made of silicone, and it's a barrier at the cervix to prevent sperm from moving up into the uterus to fertilize the ova. It was developed to expand the basket of products while having interactions with women, their partners, healthcare providers in multiple countries. And it's different, very unique from the traditional methods, in that the traditional methods, most women will have to see a healthcare provider and get fitted, but this is a one-size-fit-most diaphragm. So because of that ease of use, you can eliminate the need for a provider in most scenarios. It's soft, it's durable, with features that allow women to easily insert the diaphragm. It has grip dimples that makes insertion easy, and a removal dome that also makes removal easy. Because of the silicone make of the diaphragm, it's also very comfortable for both the woman and her partner. So background, in Nigeria, we have over 200 million people, and 31 million women have an unmet need for contraception. Out of that, an additional 400 million actually use only natural, traditional methods of contraception. Young women as well find it difficult to get the method. Even the short-acting method, there are barriers to that in Nigeria. So you also find a number of women who want a method they can control, a method that is non-hormonal, a method that has less risk of side effects, and that's how Kaya came into the picture. Fitting the profile of this women, the kind of method this women will want perfectly. It's user-initiated, easy to use, non-hormonal, less risk of side effects, and perfect for women who do not or cannot use hormonal methods. So our activities were twofold. We had activities to increase awareness among real users, to increase awareness, targeting the audience that I already mentioned. And we also had activities with the providers who will be offering these methods in their different facilities to these women. We trained the providers, and we also ensured that the product was placed in all the channels that women usually visit in Nigeria to receive primary care. How we went about this, we explored the thoughts of our providers to find out what method or what they think the women who visit their facilities would like and the barriers to the current methods available in Nigeria. Though we have a large basket of short-acting and long-acting methods, we do still see that a lot of women were looking for a method they could control, method that seemed natural, and a method without the fear of side effects, because side effects is the biggest cause of discontinuation within Nigeria. We also, like I mentioned earlier, trained the healthcare providers to be able to counsel women around this method and to be able to basically teach them how to use the method correctly and the advantages that this method has over other methods that they would rather not use. Most of our trainings at the time of this study, which was a 6-month period, was just after the COVID lockdown. From that time in 2021, from January till June, we had most of our trainings online, virtual trainings, and a few on-site trainings. We created awareness around multiple targeted channels through the providers, digital media. We use social influencers who already have a large following on their platforms to create more awareness within their followers and around our target audiences. We also collaborated with other organizations who work with women who fit the ideal profile of a Kaya user. Some of our findings include our providers and the users were very accepting of Kaya. So we found that our introduction was practically successful in our opinion. Our focus group was within the 23 and 35-year-old women, and we had outreaches targeting these women, and the reception was also found to be very successful within that group. Within the study group, we were able to train 160 healthcare providers virtually and over 1,400 providers within the different facilities with 82 facility-based trainings. At the moment, at the time of the study in Nigeria, we had 430 facilities where women could walk in to get the Kaya diaphragm. We're also able at the regulatory level with the Federal Ministry of Health, we're able to get Kaya, discussions ongoing on how to get Kaya integrated into the essential drug mix for the country, for our country. And this is important because having Kaya within the EML for the country ensures that all facilities within the public and the private sector can stock Kaya and include that in the mix for women who work in desiring a contraceptive method, especially non-hormonal, which is a method of interest for women in Nigeria. Women who we found also, like we already suspected, that the women who found Kaya interesting were women who want to take control of their own sexual reproductive health, women who already use a natural method, which we know is less effective, but find Kaya to be more effective and easier to use, women who have infrequent sex and do not think they want a method that they have to have within the system while their partners were not going to be available to have sexual intercourse. They found Kaya perfect for that use. So through social media, we also realized that a lot of women found Kaya to be suitable because they do not require to see a doctor, number one. And two, another thing we did realize was, in spite of the fact that you could eliminate the barrier from providers, a small category of women still would want to see a healthcare provider for that personalized care and initial transition into using Kaya. And from that point, they found it easy to use on your own. To summarize our results, like I said, we found introduction to be partly successful within that short time frame, and considering the challenges that come with introducing a new product in Nigeria, we also did find that raising awareness and training of providers was relatively successful, and it did translate into more women having access to the Kaya diaphragm in Nigeria. We are at the moment revising our plans to include more social media influencers who could increase our reach and to make the awareness about Kaya even farther than we've taken it so far. And we do know that these are strategies that other brands have employed and have been highly successful. So with support, we know that we can do so much more and reach more women with Kaya. Here are some testimonials that we received from our digital platforms on Twitter, Facebook, and Instagram. You will see that there are a number of women who share their experience with Kaya and their satisfaction with the method. Here are more user testimonials from our social media platforms. We also have testimonials from providers who, prior to the time where Kaya was registered, introduced and registered in Nigeria, had to turn away women who did not have their method of choice. But now, as you'll see from the testimonials displayed, that the experience of both the provider and the users with Kaya diaphragm has been very satisfactory. Okay, just some more. So our lesson so far, having Kaya diaphragm in our basket of products definitely increases the choice for women. And like I mentioned before, we have a substantial number of women who are not on any method or prefer a natural method or cannot or do not want to use hormonal contraceptives or are not satisfied with their current hormonal contraceptive method. Women appreciate Kaya because it's user initiated, it's non-hormonal, it's reusable, and because it also helps them to control when they want to have their children. The introduction has been successful in Nigeria, and we plan to do more with more support, and we believe that it can also be successful in other countries where there's a high unmet need for contraception. Okay. Marketing approaches definitely will help, but we were not able to do that in Nigeria because there are a number of restrictions around advertising medical commodities. Cost is another limiting factor. Even though it's reusable for 2 years, the initial cost is about $13 to $20, especially when you add on the gel. But because of that initial high cost, most women find that as a major barrier. So with more support, it can be subsidized, and we can have more women enjoy the Kaya diaphragm. Thank you.
Okay, thank you to Dr. Biobaku for that great presentation. And also, I love the color of that diaphragm. It's beautiful. Okay, so our next presentation comes from Dr. Yewanwasu Tilahun. However, Dr. Yewanwasu has a sore throat today, so unfortunately, he's not able to share his presentation, but fortunately for us, he brought his boss with him, and she has offered to share the presentation on his behalf. So this is Dr. Luam. Dr. Luam will be presenting for Pathfinder International, but I will share just a little bit with you about Dr. Yuan Wasan. He's a gynecologist and obstetrician and Master of Public Health Specialist. Since 2008, he has been with Pathfinder International in Ethiopia as a senior FP-RH advisor. Before joining Pathfinder, Dr. Tilhun worked with a consulting gynecologist and as a consulting gynecologist and obstetrician in the public female hospital in Abeba, and also served as the medical director for the hospital. And so Dr. Luam will be presenting expanding access to long-acting reversible contraceptive through an integrated backup LARC service support.
Good afternoon. Thank you so much. I will be covering for Dr. Yondesa. So I will present on how we have increased access to contraceptives and added LARC methods, long-acting reversible contraceptive methods, by using integrated backup support in Ethiopia. So just to give you a little bit of background, in 2009, the Ministry of Health of Ethiopia have introduced and launched the Implanted Scale-Up program. It was by task sharing, skill training to health extension workers, which are our community health workers, on implant insertion. And it was given at health post level, which is the first level of health service in Ethiopia. And prior to integration of the implant scale-up at health post level, only short-acting methods were being provided at that level. And this scale-up to the health extension workers have provided an option for clients to access implanon at the community level, but the removal services were not being given because only the insertion service was provided. The insertion training was provided to our health extension workers. So after the scale-up, we were faced with the clients requesting for a range of other family planning methods and services. And with the assessment we've done, the ask for the LARC methods, including removal for implanol. They wanted to shift to other methods or to get pregnant was a request coming at the community level. And this has led for increased referrals of our clients to the health center level, which requires them to travel and get those services. So to address this gap, Pathfinder International, with the support of USAID, has introduced an intervention called Integrated Backup LARC Service Support from health centers to the rural communities. So when we introduced this integrated backup LARC support to the community level, we have done several interventions. And the first one was giving trainings to healthcare providers at health center level on LARC skills. We provided also consumables, which are very important to provide those services, and also insertion and removal kits. And we have also done regular supportive supervision activities so that they will be able to integrate this backup service to the community in their health centers. And in addition to that, we have supported those health centers to do regular planning of these backup support activities to the health post level. So after implementing those interventions in 5 years' time of the project, we have done an assessment to see the effectiveness of this intervention. And there was a mixed method study was conducted in December 2021, comparing health posts, 45 health posts, which received integrated backup support, with 40 health posts which didn't receive an integrated backup support. And we have also done an additional qualitative study with 20 key informants to see their views on integrating this backup support approach. And we have done all the statistical analysis and data collection methods based on the standard. So just to show you the major results and key findings we have found, there was a significant difference in the time spent and other supplementary costs for clients coming, family planning services, for clients coming to the health, there was a significant time and transport challenge for clients going to the health centers to access those services compared to the ones which are getting backup support at the health post level. And there was also an average 1-year LARC and short-acting family planning service supported health facilities with increased uptake of services. And this was compared between those who got backup support and those which didn't get backup support. And the other major result we have found, which we showed that the basket of contraceptive methods has increased at community level, was clients who visited or supported with the backup access, an average method of the health posts with 7 methods were available. And those health posts which didn't have a backup support, only 4 methods were provided. And from the findings we've had from the key informants, the major thing we have found was they all agreed that organizing and conducting and following up on activities, including recording and reporting of the services, were performed by the available human and financial resources in the public sector, because it was integrated as part of their planning and implementation activity, and it has helped them to increase access to services at community level, which include also LARC methods. And the other, the major program implications and lessons we have learned was family planning services. Family planning services are not available at community level, like at health post level, can be provided by the integrated backup LARC service provision model from their catchment health centers, which has increased access for services. And clients can get family planning method of their choice at the village level if we introduce this backup support. And clients can also save their money and time spent by traveling to the health centers to get the method of their choice if it's given at the community level, and with a number of method choice available at health post level, they would be able to save their time and money. And if the integration is if the intervention is well organized and implemented through integration to the existing primary healthcare unit, healthcare system, using the available human and financial resources, it will be a strong mechanism to reach the community. So this has also shown us that enhancing local capacity and self-reliance of the public sector can ensure continuum of care for family planning services. It can ensure sustainability and equitability for quality of family planning service at the rural community level, which has shown a big result as part of this project. We have also concluded that the backup model can be an alternative approach to the traditional mobile outreach service, which is usually implemented by implementing partners, because when a project ends, if it's a mobile outreach service, the resource will be finished, and the backup support is, compared to that, is very strong, because all the trainings, the system, the planning is led by the government itself, and it will help sustain the results and increase access for our clients. Thank you so much.
Thank you for sharing your experiences with that. And I think that I neglected to mention that Dr. Lawam is the technical director at the Pathfinder Ethiopia office. Okay, so our fourth and final speaker today is Ifran Khan, who manages the Strategic Engagement Network on Family Planning and Adolescent Health at the Population Foundation of India in New Delhi. He brings more than 2 decades of experience in the development sector and has worked in many areas, including HIV, SRH, and urban health. He is a firm believer in people's autonomy and right to choice. He is stepping up for people by expanding contraceptive choices and changing the family planning discourse from commodity-centered to people-centered, and is the Associate Director for Family Planning at Population Foundation of India. He will discuss policy engagement for the introduction of new contraceptive methods in the public sector in a case study from India. So I'm excited to hear your presentation.
Good afternoon. Just a moment. Yeah, I think that will be better. So my fellow presenters actually talked about the challenges and the sort of the steps involved in after the introduction of a method, what it takes to sort of follow it up and see that it's implemented in a right manner, that it reaches the clients. I'm going to take a step back and basically sort of talk to you about what it takes to actually introduce a method and to sort of add it to the existing basket of choice. And that comes from our Population Foundation of India's experience of a long, well, I won't use the word battle, but a journey to advocate for introduction of a new method in the Indian basket of choice, which was the DMPA or the MPA. So I'm going to talk about that. Before I do that, I think I'm going to invite someone, and someone's going to walk from that door, a woman called Uma. Do you see her walking in from that door? No? Okay. Oh, there she is. Thanks. I was just checking if you're attentive or not. So I'm going to kind of tell you a story about Uma, a young woman, married, small child, and husband supportive, working in a manufacturing unit. And she has dreams about having a small, beautiful family, a small, beautiful home in a small city. And I'm sure when I narrate this story, I'm sure you would have, thought of a face that you might have interacted or sort of come across who also has similar dreams, right? And therefore, she doesn't have a face right now. In fact, she could be one of those 22 million Indian women who are in the reproductive age, want to use a contraceptive, but are unable to do so. And Do you know why? Well, one, because she does not have the correct and the accurate information on FP and the FP methods. Because she has a very unfavorable socio and cultural background to sort of navigate through, and that kind of makes it hard for her. She also has to deal with a lot of myths and misconceptions that she might not have like learned, but has gathered from her peers and you know, from the community. And if and when she actually reaches a stage where she decides to use a contraceptive, I think what she ends up with is not having a method of choice. And therefore, she's actually not able to use a contraceptive. Now, in low resource settings, I mean, it's very sort of common to see that when a woman visits a facility where it's intended to sort of provide at least 4 or even 5 methods of contraception, the woman goes back home either with a method that she didn't choose or something that she never got. So, what happens? This is what we see. Either women don't accept or adopt a method, or they end up taking a method which skews the complete method mix. And this is a kind of a disturbing image that you're seeing on the screen, which is kind of showing, if you see, female sterilization, which is a permanent method, actually eating up more than half of the pie of the entire basket for choice. And why I say that's disturbing, because that's not spacing. That's like when you've planned your family and you want to end how many children you want, this is what you adopt, right? So that's the problem that we identified, and as a result, I'm sure we all know what are the issues behind this. It's about poor outreach, it's about lack of counseling, it's about provider bias, it's also about poor follow-up and side effect management. But at the same time, it's also about limited temporary methods, as I talked about. So what we did as a national level advocacy organization, Population Foundation of India thought of expanding the basket of choice. And well, these are what we have in the Indian basket. What we added was, or what we advocated for, was the introduction of the hormonal injection. Yeah. And so how did we do that? I mean, was it through media advocacy? Was it through talking to the providers? Was it through engaging the relevant stakeholders? I would say it was a mixture of all of these. And in fact, this is, I've sort of tried to boil it down into what are those 3 critical sort of steps or ingredients of having a multi-pronged advocacy strategy. So Population Foundation of India being a consortium of a collective of organizations which is working on expanding the choice of women on reproductive health, we leveraged this entire group of CSOs. We built evidence-based narrative and discourse around the importance of expanding the basket of choice, but at the same time about the MPA. And then we engaged with the relevant stakeholders to advocate and make, sort of educate them or sensitize them around the need for adding this. So, okay, these were supposed to come one by one, but I don't know, maybe there was a glitch. So what are the strategies that we adopted? And these are very sort of, not from the textbook kind of a thing, but if you see, these are very practical and tried and tested strategies, which Population Foundation of India has been sort of trying for the last more than 3-4 decades. First one is about developing and sharing evidence. And MPA has been in the Indian private sector for almost 30 years now. And while we were talking about this, it was already there. Providers were giving it out to women who were coming to their clinics. So we had the data, we had the information, we had evidence of it being safe, effective, and efficient. But at the same time, it was not being adopted in the public sector. So we presented that evidence. We also sort of wanted this message to be sent out through a cadre of champions. I mean, as they say that messenger is as important as the message. So we reached out to people in the community, providers, elected representatives, policymakers, to sort of understand the data and the evidence we're talking about, so that they talk about that with the policymakers. We also engage the media. I think we've sort of seen that in the previous presentations also, that how media sort of plays an important role in expanding and sort of ensuring that the information reaches out. We also worked with the technical bodies. I mean, because this was about a new method, which was hormonal, and therefore, I think we needed to sort of get the buy-in and an endorsement from the providers, from the technical bodies. We have this Federation of Obs and Gynae in India called FOGSI. So we sort of got them to make statements on the efficacy and the safety of this method, and that actually worked in our favor. And most importantly, a collective action, a collective voice. And that was, I think, the most crucial factor of the advocacy that we did, that we didn't go as one organization or a one representative, but it was a collective voice of the entire consortium. Just to end, oh, this one is working, all right. So what did we learn? Sorry, this is the previous slide. Okay. Oh, sorry, this works the second time. So, so what are the lessons? I mean, from this, as I said, the journey of advocating for the introduction of MPA, which was about a 12 to sort of 16, 18-month drawn process. This is what we learned. One is we need to sort of keep a track on the current narrative. What is being talked about? What are the issues that the providers or the policymakers or the decision makers have about which is against the introduction of that method? And that helped us to sort of create the evidence and the narrative that I'm talking about, which helped us to sort of reach out to the relevant stakeholders. Simplify data. I mean, we talk about numbers, we talk about this ratio, that ratio. I mean, with all due respect to the research and all that goes into creating that data. But I think we need to break it down. We need to simplify that, because we're talking to the policymakers, to the decision makers who may not have that bent of research or a scientific sort of interest, and therefore you need to do that. Myths and misconceptions. I mean, one of the, I'm sure you would agree with me that with MPA, and in one of the earlier presentations you might have seen that the dropout was majorly because of some of the side effects and some of the myths around that method. And so it's important that we address that and kind of hit that fast and hit that hard, so that it does not affect the community in terms of its adoption. Again, back to having a collective voice. It's very important, as I said, that in this effort, one of the crucial ingredients was that we went as a collective and not as an organization by ourselves. And not to forget that, again, in this also we realized that one of the biggest opposition to introduction of MPA was actually some of the women rights group who believed, or who rather thought that this is actually going to be harmful to women, and therefore we could not reach out to the communities as well as to the policymakers. And despite it being in the private sector for 20 years, there was a section of women who were not able to access it. So we engaged with them. We sat across the table, talked to them, heard what their issues are, what their opposition is, and try to sort of deal with that. And I think that was something that helped us to get a lot of them on the other side of the table and join us in being that collective voice to reach out to the stakeholders and make this effort success. Thank you very much.
Okay, can y'all hear me? Okay, thank you. So we'll have our panelists stay up here. So let's have another round of applause for all of our panelists. I think that was great. And thank you for allowing me to sit up here with you and to hear about these experiences. You know, I think it's important to consider all of the things being spoken about up here as we're talking about some of the, you know, new methods that are being introduced or created that increasingly center on the needs of users and of women. And how the multiple layers that go into introducing those into any system, and you know, the providers, the community, the health system, the policy and advocacy and the funding is all very valuable to hear about and consider. So what we'd like to do now is open the floor up for questions. So if you have a question, I ask that you come to the microphone in the middle of the room so that we can all hear you, and then we'll let us know if your question is directed for a specific panelist or if it's a general question. So please, if you have a question, stand up. Yeah, please, if you don't mind, there's a microphone here for the questions.
Thank you. I appreciate Dr. Irfan's presentation. And he mentioned about engaging stakeholders. Can we know who are those stakeholders and some interesting or out-of-the-box stakeholder that you have engaged, which was not there earlier?
I think I'm loud enough, or okay, maybe for the recording purposes. Yeah. No, in fact, you know, when we sort of talk about the stakeholders, especially from a policy designing perspective or executing or implementing or an addition of another layer of programming, I think we all know within the kind of systems that we're working with, it's primarily the officials, the decision makers with the ministries of health and departments of family welfare or family planning in different countries. It's with different terms. Also, I think it's definitely media, but I think here we, as I said, I know we didn't want to do something very different for being sort of you know, seen as a outlier, and therefore we kind of followed the principles and our lessons from our advocacy work over the last. I mean, we've been in this area of advocacy around FP and reproductive health for the last 50 years now. So we didn't want to sort of create a separate you know, channel for engaging with the stakeholders. So I think if I were to list them, it would be decision makers, certain elected representatives, because they obviously you know, create that that pressure or kind of a influence on how policies are structured at the bureaucracy level. So those were the usual sort of stakeholders that we engaged with. Thank you.
Do we have other questions? And also, if any of our panelists have questions for other presenters up here, please ask them as well. Oh, yeah, please.
For Dr. Lopa.
Could you pick the microphone up?
Okay. Can you hear me now? Moving forward, thinking about, for instance, scaling the injectable contraceptives you mentioned, do you see any concern in terms of scaling it up, or from the issue of financing or anything?
Am I audible? This? Yeah. So in the project we have talked about, the Salamati project, which was ended in in 2019, and already you have seen that project made a complete dent in this complete your structure. It has improved that contraceptive injectables quite a bit within the country and as well as in Haryana and on those districts where we have worked in. So when you say for scalability, definitely, because we started with 7 districts and then the government has taken up and it has been now the same system has been provided for the all 15 other districts in Haryana. So it has been launched by their state government and then it has been taken up and the similar system has been, because this project was not had started within a 2-year project, then got a supplementary grant and then has been added up. So it has been BMJ funded project. So you can see the scale up was also inbuilt within the project. And then when the government has take up those kind of system has been already established, institutionalized within the system. So that's the way the scalability has been happened. Thank you.
Thank you. Are there other questions? Yeah, please.
I had a quick question to Dr. Lokmudra and Irfan as well. In your study specifically, what was the impact of access or availability from the market, the product, that caused the dropout rates? Because when you go for a second, when a user goes to the clinic again or expects the dose to be provided as a take-home this thing, if that product is not available, that could be a very critical impact in the dropout rates that you've seen. There might be a intent to have the second dose, but if it's not available, it's not available. You have to move to another method. That was question number 1. And the other question to Irfan, is there anything which PFI is working to improve the availability of the product in the market? Because you can do as much as you can for availability of at a policy level. But downstream, when you actually hit the market, you don't have products, you have stock out issues that are being discussed across all forums that we have seen on self-injection. It's a major issue to address, and some thoughts on those lines. Thank you.
So I take my questions first, and then I think Irfan can start. So I would like to say that this project was talked completely with the public health sectors. You must have been seen that the 85, total, with including one medical college, has been enrolled, and we have gone till the sub-center level. Definitely, I would say the stock out in the service, government service, was an issue that point of time. And there we have started with a follow-up mechanism that you can keep the stock registers and can institutionalize this complete monitoring system, that how much it is be that next dose people may come for when they are coming. So it has been included in the HIMS system, the data system, and that gives you the complete thing. So Pathfinder also has worked to strengthening that system with HIMS data on those 7 districts, and it has been taken up later on. So this is the way, because I also wanted to say it was not I said top 3, definitely that point of time, but yes, stock out is also one of the cause, but it has came very lower level, because that has been also for the supplement grant. When we have got it, we have found that was a challenge and we have taken it up. So that was very important, and thanks for raising these questions.
Just to sort of add to that, or rather to take up the second part of the question, you're very right. I mean, many times any new intervention or introduction of a new method sort of fails when in the rush you introduce it, but then you don't have a strategy or a follow-up sort of mechanism to ensure that it's available and when you have more users to use it, and when you say that I can't provide it, then that's a failure from the supply side. Definitely, we don't sort of stop or consider our battle won once the introduction is done. But we constantly have been working with the government on strengthening the systems in terms of the supply and supply chain management. We've also been sort of working with them closely on the manufacturing front, because still it's not not many sort of manufacturers within India, if I were to say, are manufacturing MPA. And I would like to say that we've sort of come a long way since then, and there are now uh, uh, sort of negotiations that are happening between manufacturers where this would be locally produced. We also sort of, as Lopa was saying, around using we have this logistic management information system, which is an app-based or a mobile-based system, which right from the frontline worker to the central warehouse can track how many different contraceptives are at different public health facilities. And that is something that we're also sort of helping the government to strengthen its usage and implementation in terms of uh, forecasting and also having enough stocks at the facilities as per the requirement. So I think those are some of the steps that are part of this entire engagement with the government and the relevant stakeholders. Thank you.
Thank you. I have a question for our panelists that I'd like to pose to all of you for anyone who has a thought. I'm curious what you think about how introducing a new method in a context affects the basket of contraceptives in total, because I think I attended a session this morning about provider bias. Maybe some of you were in there, and it was interesting to hear about how, you know, when you introduce a new method in a context, and there are targets set for that, and there's funding put towards it, sometimes it can displace resources for another method or displace another method in that setting. And so I'm curious what your thoughts are about the introducing a new method and how that impacts the basket of contraceptives available in that setting in general. Does anyone want to? Yeah.
Yeah. I mean, in a way, you're right that initially, as soon as a new method is there, and as I said, there's a rush and there's this extra sort of effort to popularize it or have more people adopt it. But given the fact that we know a lot of research says that adding one method kind of raises the adoption rate by anywhere between a 4 to 8 percentage points, and that's something which I think we should always be happy about or contented with. Yes, there might be pitfalls around one method getting more popular than the other, but I think it also depends upon if that's the method that is getting accepted and has a wider reach and acceptance. I think we should not be worried about the skewedness. Also, I mean, I'm purely speaking from the Indian sort of skewed method diagram that you saw. Anything that cuts the pie off the terminal method, that's the female sterilization, and gets into any of the other remaining sections, I think we should not complain about that. Thank you. I think Lopa wants to add something to that.
Yeah, I also add with that what Irfan has said. Yeah, because here in Indian context, you will see that the female sterilization is definitely it's gone almost in 60% is there whenever we saw. Yeah. So now where the pie is going to get cut? Actually, the adding another reversible contraceptive methods, that's definitely giving us more choice, more acceptability, and cutting the pie there. But also you have probably have been saying there, also giving people, like when Irfan also told that when people say that they have completed their desired family size, then they have gone for sterilization. So this is one set of people. Of course, they probably go for sterilization, but more option where is coming for spacing, right? Or to starting the new family, probably from marriage to first birth. There you are giving people more option. And there women, I think, need more options because there is only condom. And if you've seen that option when I have shown, there was earlier the condom and in injectable when came and introduced, it has been also going side by side with OCP. Right. So that's a scheme as a second best choice along with OCP. So that means the new method has actually taken up that area which Irfan said, that is actually increase the use of contraception to 4 to 5%. So I agree with that, and that gives us more confidence to bring up more method for reversible contraceptive in the basket. Thank you.
Thank you. I think adding a new method is very important for the clients first because it increases a choice for them. But initially for the providers could be also a burden. Like it's a new training, new skill. They will be agitated initially, but over the years they will accept it and it can be provided properly, which is a good one. But it also brings an ask from the community, like for the implantal scale up, we only trained initially for the insertion. We didn't think about the removal service. So when clients were asking for removal service, more trainings and or they have to go to a far health center to get the removal service. And it also helps them to know that the other methods like Jadel and IUD were known by the community and they were asking for them, and the government has started to think about how they would be able to increase the access for the LARC methods. And they have also expanded the services, which has shifted our method choices, like the access for service has increased and the prevalence of the injectables has reduced slowly, and implant uptake has increased progressively, which has helped a lot for the country to have more people more on the more effective and efficient methods. Thank you.
Thank you. Nigeria is peculiar. Usually, when there's a new method, interest spikes. In my country, when you ask most women, they know about family planning, but adoption rates are still significantly low. So when we have these opportunities like with Kaya, you see more women are, open to try out a new method, and it doesn't impact the other methods negatively. You still have the profile for each method. It's different in my country. The woman who wants a short-acting method, even a pill or a condom, or a woman who wants an injectable or IUD, different profile. And so for the Kaya, it's very specific. So now having a method that fits what this woman needs just opens up a new horizon, and we're seeing more women open up to family planning. And when they enjoy that method, they encourage other women in the community to try out what suits them, even if it's not the same method. So generally, it's a win-win to always have an ever-expanding basket, so everyone finds what suits their immediate needs. Thank you.
Hi, this is Manish from Pathfinder India. I have a question for Irfan. So Irfan, in terms of policy work, does the nature of the method also makes the task more difficult or easy? For example, the potential user cohort, short acting, long acting, and the financials part of it. So your experience on that one.
Definitely it does. And I think there have been instances where, not only from India, but other countries also, where introduction of something that does not involve a lot of changes or rather additional layers to be put into the system in terms of training, in terms of developing a protocol of service delivery or provision. I think those have been taken up much easier or without much resistance or delays from the government side. But when it comes to methods which, like for example, now we are working towards the introduction of implants. And I think that's also been going for some time now. I think we've sort of hearing from the government that it's very soon that it would be out there in the Indian public health system. So I think the fact that implant is also something that's been there in the market since many years now as MPA, but it would have been much easier to sort of introduce the methods together or at a shorter interval gap. At the same time, there are other methods which are also introduced along with MPA, which did not get the kind of attention that MPA or other methods get because of, as you rightly mentioned, that it actually needed a complete, well, I won't use the word overhauling, but a lot of training and creating an extra layer of system preparedness to sort of take the load when people come to that. Because this 3-dose thing is a challenge. It's always, we see a large number of women coming for the first shot, but as Lopa also showed, that second and the third shot, we kind of see a drop in continuation. So that was something that was one of the challenges that the government was not very keen to sort of, put their hands into. But I think beyond a point, yeah, they had to give in to the demands of of the CSOs and other players that were working for it. Yeah, thanks.
So do we have any other questions from our crowd or from our panelists? And if not, we have a few minutes left, so we can wrap up a little bit early. I want to give an opportunity for any of our presenters to add anything or say anything more that they didn't get the chance to. Or you feel you've been able to say everything you wanted to. Okay, so I thank you to all of our presenters for sharing each of the presentations today. I think it was great to hear about the introduction of these different methods within the systems and the different layers that were involved in that, and to hear some of the questions and comments that followed that. So I hope you'll join me in thanking our presenters and giving them a final round of applause. We have a little extra time to stretch your legs before the next session.